Hi, I'm Tim Wiedrich, Section Chief for the Health Response Section with the North Dakota Department of Health, and this is our monthly statewide tactical long-term care meeting relative to COVID. Thank you so much for participating with us. I'm going to go ahead and remind folks to go ahead and make certain that your microphones are on mute. Please, everyone, go ahead and check yours right now because it does interfere with our ability to do the program if you haven't muted your microphone. So please make certain that you're checking that. As I began saying, this is a jointly sponsored meeting with the Long-Term Care Association. And Shelley Peterson is with us. And let's see, Shelley, if you have any opening comments.
Tim, it is a pleasure to be with everyone today. You know, I think of a year ago and where we were and all that we didn't know was coming before us last fall. And so I'm just hoping as we get into our late summer now, which is sad to say, we're almost into August, that we don't have a repeat. So I'm glad we're keeping the monthly communication, the contact with everyone, and hopefully we fare well this fall. The thing that is remarkable and wonderful is that the vast majority of residents are vaccinated, and that's being shown in the numbers. We have so few resident-related infections and or deaths. And before, you know, our numbers are really quite high. So excited to be where we are right now, hoping for a good fall. The other thing that was kind of newsworthy is Sanford Good Sam's announcement this morning to their employees that they are mandating COVID-19 vaccine. We know that some of you are considering that. We had talked about it at our last meeting. And so I think this will help pave the way for others that have been contemplating that decision, knowing that it would be a difficult one, but probably a good one for their workforce. So we're really looking forward to having continued discussions with our members on the whole issue of mandating vaccine and being best protected, as we're not sure what lies ahead of us yet. So with that, Tim, I will give it back to you.
All right, thank you so much. Well, we're going to go ahead and lead off with some very important information. Jenny Galbraith is the leader of our vaccination, COVID-19 vaccine program, immunization program, and she has some information to share with us. And so, Jenny, it's yours.
Thanks, Tim. I am going to go ahead and share my screen, and we will get started here. And while that's coming up, I will just go ahead and jump right into it. So, as Shelley pointed out, we do have excellent vaccination rates in our residents here in the state of North Dakota. So as you can see, for completion of the vaccination series, we do sit at about 92.73% for those who report through HG Standard. As you all know, SNFs now have to report through NHSN. That goes and is reported on the CMS website. So that sits at about 90.5% for those SNFs. We are still reporting out any of you who report into HE Standard, your updated numbers into our overall rate. So this is a little bit of a double reporting, but regardless of the number, it shows that we are in a really good spot with our residents right now. Here is a map or just a quick overview of kind of all the states and what their SNF rates look like. North Dakota is one of the top states, so that is awesome. And we're really excited that all of these residents, and through your hard work, we have all these residents protected. Staff, we are faring a little bit less good. It is still important, though. We are still continuing to see increases every week. So I'm really happy that we're not going downhill or kind of staying stagnant. They're small increases, but any increase helps at this point. So we are sitting at about 60% or so for our staff who have completed the vaccination rate in North Dakota. Unfortunately, we are not at the top of the list as far as SNFs overall. We do sit kind of in the middle of the pack. So we would love to see our numbers higher to make sure we're protecting our most vulnerable population that you guys are taking care of. So we do have a number of all-stars still. And again, those are individuals who report 80% or more coverage rate for their facility. And as always, if you guys are on this list and have done some new, exciting, fun things to kind of increase your rates, please let us know, and we'll love to share some best practices out with you all. So something you may have seen a little bit in the news, the Johnson & Johnson vaccine and the Guillain-Barré syndrome. So for those who aren't aware, GBS is a neurological disorder that the immune system basically damages its own nerve cells. And this can range anywhere from mild to severe, with severe cases causing paralysis. So they did pick up some cases of GBS following vaccination with the Johnson & Johnson vaccine. So there were about 100 cases reported following about 12.5 million doses administered. 95% of those cases were serious and they required hospitalization, and there was one death. Currently, the ACIP is meeting actually right this moment, and they are talking about this. But what it does look like is that even with this GBS, the risk associated with COVID vaccine is significantly lower than any risks that are associated with COVID disease. And it is important to point out that GBS has also been reported after COVID disease as well. We don't have a great rate yet. All of those studies have been case studies, but it does look like it is something that happens naturally as well. And another important note, this has not been associated with the mRNA, so the Pfizer or Moderna vaccine yet, or at this point. And we don't really assume that it's going to. We have a lot more safety data on these vaccines. I did just want to quickly bring up booster doses. You have probably heard in the media Pfizer submitting for approval or authorization for a third dose. So the ACIP is meeting to discuss the need for booster doses for immunocompromised individuals. So right now, there's no recommendation. If you've gotten your either 2 doses of mRNA or 1 dose of Johnson & Johnson, we still consider you fully vaccinated. But it is important that as long-term care facilities, you start looking at what that would look like if Oh, and it looks like I've been unmuted. Awesome. So it's important that long-term care facilities do look at what that would look like if I needed to vaccinate my long-term care residents with a booster dose. So if you're signed up to receive COVID vaccine through the state of North Dakota, great. Would that look like you're a partner with your pharmacy like you do for the flu? Would that look like a partnership with local public health? It's important that you start having those conversations now when and if that recommendation does come down the pike. We want to make sure we're prepared and kind of can float that booster dose out relatively quickly. I did want to touch briefly on the Delta variant and vaccines, and I'm not going to steal Dr. Carson's thunder, but basically, long story short, is that early research does show that the vaccines available in the United States do offer protection against the Delta variant. It might be a lower protection that we would see against the original strain of COVID, but there is still some protection. So Pfizer is reported to be about 88% effective 2 weeks after the second dose against the Delta variant. And this is compared to about 33% after 1 dose. So in North Dakota, we actually are sending out letters to individuals who have only received 1 dose of the mRNA vaccine and need to get up to date. And I would take a look within your facility. If you have any residents or staff who have only received 1 dose, it might be a good time to start talking to them about receiving that second dose to make sure they are protected. There's also data to show that the Pfizer vaccine is very effective against severe disease, so like admission to the hospital after 1 dose, and even more effective after 2 doses. We don't have great data yet on the Moderna vaccine, but it's very similar to the Pfizer vaccine, and we would expect that they would have very comparable effectiveness. So there's not real-world effectiveness data yet for the Johnson & Johnson vaccine. However, it does look like there is some reduced effectiveness against Delta, but we are still looking at those numbers. And there is still data coming out daily about what this looks like. So as we get more information, we'll be happy to share with you. And that's all I had prepared, but I did want to just quickly throw in a plug that the Delta variant is here in North Dakota. We've already sequenced it. By the time it makes it into your facility, it is likely too late for you to do anything against the Delta variant. It's much more infectious than the normal strain of COVID that we already have. And I would just push a plug that if your staff is not vaccinated or still sitting on that wall of getting vaccinated or not, now would be a really good time to start talking to them and start pushing that education again. As Shelley said, we have a really low number of cases in residents and any really don't have a whole lot. I would hate to see any unnecessarily breakthrough cases that lead to hospitalization or death in our residents because people around them aren't protected from COVID from the vaccine. And that's my plug, and I'll stay around for any questions at the end.
All right. Thank you so much, Jenny. Let's turn now to Kyle Hall, who's with North Dakota State University System, who has some information about a vaccination education program. Kyle?
Thank you so much. Let me get my screen shared here. I just have a few slides and then I believe we're going to talk to Dr. Carson. So I'm here today to talk about, are you able to see this, everyone? If I share
Kylie, we can see it, yes.
You can see it. Okay. Can you see it in full screen?
Yes.
Okay, perfect. So I'm here to talk about COVID-19 vaccine education that we are offering for long-term care facilities and their staff. We have 2 educators in our center. I'm one of them. And then Lauren Dibson, who's not on the call today, she is also one of our educators. And we are able to come in and do some education in your facility. So what are we offering? Well, we're offering tailored education that is unique to the needs of your facility. And we like to make sure it's something that fits with what your needs are and what kind of your time constraints are and things like that. So as far as time is concerned, we can do the education for as little as 15 minutes, and we've done trainings up to an hour, depending on what you would like us to do. For delivery, most of them have been virtually done. We have recorded some videos, and then I will put a small plug in here. We've done a few on-site visits to facilities, but those are very limited based on the availability of Lauren and I and our schedules. But we have done some locally and in the Fargo area where we've actually gone on site to the facility to do the education. And then we're willing to do the education any way that you prefer. So we can do a formal presentation where we show up with a slide deck and we go through it. We would also just show up and do a question and answer session if that's something that you think would be helpful for your facility. I think the facilities that have taken us up on this education have found that it's good to have somebody different come in and present the information while your director of nursing or your administrator or your infection control nurse maybe has answered the questions already before. Hearing it from someone else, hearing it explained a different way. I hope that people are finding that helpful. It's a little bit of a different perspective as well. And so when we start talking about coming into your facility, we actually do a pre-training consult with someone in your facility. So whether it's that director of nursing or infection control nurse, we'll set up usually a virtual meeting or a phone call. And we want to talk about what's going on in your facility. What are the rates that you've achieved thus far? And what are the things that are standing in your way? Sometimes facilities will come to us and say, it's these 3 myths that we're really struggling with. Everybody's concerned about whether it's infertility or how quickly it was developed. It really depends on the facility, but we want to make sure that when we come in and do the education, that the topics are meaningful for your staff. And then we want to talk about how should the education be delivered. Do you want handouts? Do you want a PowerPoint? Do you want us to just come in and do a video chat with your staff? And then we want to work with you to figure out when that education should be provided. Some of the facilities we've worked with have said, it'd be really great if you could come around shift change. So if shift change is at 2:30, we come in an hour before shift change and we stay an hour after shift change, and we do 2 sessions back to back. Other facilities have asked if we could do 3 sessions throughout the day. If it's virtual, it's a little bit easier. We just pop it on our calendar and then we call in and do the sessions. But we really want to work with you on when that education should be provided. And then as far as, how long it is, sometimes we've done half-hour educations with like a 15-minute Q&A. Sometimes we'll do 20 minutes of education and 10 minutes of Q&A. It's really based on what your needs are and what you want us to come in and talk about. One of the things that I think has worked really well, we went to a facility here in Eastern North Dakota, and the nurse that I was working with put a question box outside of her office, I think the 2 weeks before I came, and she had staff submit questions anonymously. And I thought that worked really well because people could submit questions, but they didn't have to know that, Lori, the nurse, was asking a question or Kayla was asking a particular question. But we got like 10 or 15 questions that I was able to answer after the presentation in a way that I it's not judgmental as far as who has the question, but a lot of people had really good questions and we tried to get those answered for them. them. So a question box or something like that might be helpful. And we can give you other ideas as far as what has worked well in the past too. I will put a plug in for our Siri YouTube page. It's linked right here. And then if you want to contact us or request a consult, you can just email our NDSU Siri email address on the screen here. I'll also say that, Jenny on the call, any of the immunization staff at the Department of Health would know how to get a hold of Lauren and I as well. So please feel free to reach out if you would like to request a consult for your facility. We had 2 in our inbox today, and we'll be setting up consults with them before the end of the week. So thanks so much.
All right. Thank you so much, Kylie. Dr. Paul Carson is a well-known figure within North Dakota. He's a trusted subject matter expert, and he's here today to visit with us from the NDS, North Dakota State University system, regarding the variant situation as it relates to vaccine, and particularly the Delta variant. Dr. Carson?
And thank you, Tim. I'm going to try and share my screen here. And Tim, can you tell me if you see that okay?
It's coming in just fine.
Okay, great. So, and I have a few other slides. I'm going to talk about Delta, and I have a few other slides just to maybe update a couple points about vaccination and risk benefit if there's time. And I'm not sure how much time you have slotted for all the different things, but you can kind of cut me off if you need to after I'm done with Delta, Tim. I'll have about maybe 6 more slides beyond that. So the CDC recognizes what they call variants of concern and variants of interest. So as the virus replicates in people, it can be somewhat sloppy in the way it replicates itself. And so that means it introduces various mutations. It doesn't make perfect copies of itself when it replicates. And sometimes those mutations are advantageous, and sometimes they don't help the virus at all. Variants of concern are mutations that lead to a new strain, if you will, that are of concern because they are either more infectious, or they may be better able to evade the immune system from prior vaccination or prior infection, or they may be more virulent. And so right now we have 4 variants of concern: Alpha, Beta, Gamma, and Delta, and a number of other variants of interest that as such, so far, we don't see any of those more worrisome aspects of them, although that remains to be seen. So the Delta is the one that's the sort of newest kid on the block, and the one that has raised the most concern lately, and so I'll touch upon that. The World Health Organization is calling Delta the fastest and the fittest. And indeed, that seems to be the case. When it was introduced into India, we saw it sweep through that country very rapidly with these sort of horrific scenes of so many people overwhelming their healthcare system and dying that they weren't even able to manage the morgue capacity there. And they were making these outdoor makeshift crematoriums to handle the dying. And as it was introduced into the UK, you can see it kind of first started to appear in late April, early May. And by mid-May, early to mid-May, it had become the predominant strain and has really kind of introduced a new surge or a new wave in the UK. And I'll point that out a little more distinctly here. Both the UK and Israel are both seeing significant rises, a third or fourth wave, depending on how you count that. And these are 2 of the most vaccinated countries in the world. The UK has about 68% of all people having at least 1 dose of a vaccine. Israel about the same at 66%. And despite those very good vaccination rates, they are seeing resurgent cases, and several of the places in Europe and in Israel now are contending with reinstitution of masking mandates and lockdowns, etc. And these are predominantly occurring in the unvaccinated, overwhelmingly, these cases. If you kind of compare this to the most recent variant, the Alpha variant, that variant was about, depending on the studies, 43 to 90% more transmissible or more contagious than the original strain. Delta is being compared to Alpha, and Delta is about 65% more transmissible than Alpha. So that puts it somewhere around double or more and its ability to transmit. We previously heard reproductive numbers. That's the number of new infections typically generated by an index case, with the original strain being somewhere around maybe 2.5, 3.5 on the high end. Experts are placing Delta to be somewhere around 6 to 7 reproductive numbers, so much more contagious. And this is a little bit of a busy slide, but this was out of the UK. And it's pointing out that in the gray bars here with an earlier strain, which would have been April through early May, would have been predominantly alpha. You can see the distribution by age group. It's kind of across the board, maybe a bit more in the 25 to 34-year-olds. But with Delta, it's much more in the young. Here you see 5 to 12, 13 to 7, 18 to 24. It's selectively affecting the young much more frequently. And this, again, sort of a busy slide. This is looking at the UK data, but deaths and hospitalizations, kind of pre-vaccination rollout, post-vaccination rollout. And you can see deaths and hospitalizations overall falling really well until very recently. And if you break that down between those who are younger than 65 versus those who are older than 65, it's the under 65 crowd that is driving the new rise in hospitalizations and a new bump up or rise in deaths. So what do we have any data to suggest Delta is more virulent, meaning more likely to land you in the hospital or more likely to kill you? I'd say the jury on that is still out, but there are some concerning trends. So just a study that came out of Scotland very recently was they noted that Delta had become the dominant strain by about May 19th, and they looked at outcomes from April 1st to May 28th, so sort of prior to Delta. When Delta had just started to come in, 39% of the cases were Delta in this time period. They saw a greater proportion, as I've kind of already mentioned, of Delta being seen in younger age groups, like even the 5 to 9-year-old age group, and oddly enough, in more affluent people. The Pfizer vaccine in Scotland appeared to be 92% effective in non-Delta cases, dropping down to about 79% effective against Delta. But most notable to me from this study was that Delta cases appeared to have an 85% increased likelihood to put that person in the hospital. If we look here in the US, Delta has now become the dominant strain. I think Jenny showed a similar slide here. It now accounts for, in the US, 83% of all sequenced cases. And there seems to be a concentration of that a little bit higher in the Midwest and West. So I think we can count on this being our dominant strain. If it's not already within a matter of a few very short weeks, it will be the dominant strain in the United States. And getting back to that, is it more virulent? This is data from North Dakota of percent of cases hospitalized in 20 to 29-year-olds. So young, typically, a healthier group. And previously that ranged somewhere between 0.4 to at the very beginning, maybe 1.4, 1.5%. And now with very recently, and we don't know if this is Delta or not, but I have my suspicions, significantly higher percent of these 20 to 29-year-olds being hospitalized. I will qualify that by, I was having a nice dialogue over this question with a good friend of mine who's the director of disease control at Oregon Public Health. And he thinks this may be in part due to testing artifact. He sent me a graph of their data on percent of people being hospitalized, and they know that they have Delta now starting to appear quite significantly in Oregon. And hospitalizations did indeed go up. But he also notes that testing has gone way down. So this part of this, higher hospitalization, or maybe we see even deaths, may be due to we have a lower denominator, meaning we're not testing as many of the less sick people, where we were testing kind of anybody and everybody. Here, not that long ago, testing has dropped way off in most of the United States. So some of this rise in hospitalization might be an artifact. I will say, though, I tend to think there's something there, that it's real. And this is a study that just came out of China, and at least gives us some indication why it may be more infectious. And I would say gives another plausible reason why it might be more virulent. They're finding that Delta variant cases are yielding about 1,000 times higher viral load in oral pharynx than the original variant. This is cycle thresholds, and this is sort of flipped. You have to kind of reverse your mind. Cycle thresholds means how many times do you have to cycle it through the PCR machine to get a positive test. The lower the cycle threshold means there's more virus. You didn't have to cycle it as long. So with the Delta variant, they didn't have to cycle it nearly as long as they did with the original virus, meaning much higher viral load with Delta. And they also found that when you sort of look at what they called a very high viral load, which is highly likely to be infectious, at the very first positive test, they found the wild type in their prior experience. They found about 19% of them had a very high viral load right at the outset on the first positive test, compared to 81% with their Delta cases having a very high viral load right at the onset, meaning likely much more contagious right at the beginning. The time to positivity of testing has shortened with Delta. So on average, it was about 6 days with the prior wild type. That's down to about 4 days from exposure to test positivity. And Jenny had mentioned we didn't have a lot of real world efficacy on vaccines against the Delta, but we're starting to get some from other countries mostly. So this is looking at vaccine efficacy against symptomatic infection in England, Scotland, Israel, and Canada. I'll maybe just focus on the Pfizer vaccine, which is what we use here in the US. Not a lot of data on Moderna. But you can see in England, efficacy dropped a little bit. Scotland, maybe a little bit more, down to that 80%. Israel looked the worst, down to about 62, 63%. Canada, not seeing much of a drop. So it's a little bit all over. But still pretty good. But I think more importantly, when they look at hospitalizations, I don't have that written on here. This is hospitalization and death on the right here. I should have put that on the graph. It still looks quite good. In England and Israel, even their AstraZeneca vaccines, which typically have the vector vaccines, haven't been quite as good as the mRNA vaccines against hospitalization and death. Essentially, no statistically significant drop in efficacy, which I think is encouraging. Even here in with the dashed lines mean one dose. So in Canada, they've got some one dose data showing pretty good efficacy against hospitalization and death. So kind of summarizing some of this is that, Delta appears to spread a lot faster and to more people. It appears to be affecting young people more. I shouldn't say it's definitively more. I think it may be more likely to put you in the hospital. Again, that 85% higher likelihood in Scotland, a little bit higher likelihood in that 20 to 29-year-old group that we saw in North Dakota. I heard on the radio, Minnesota Department of Health reporting almost double the rate increase in hospitalization rates compared with their older strains. Again, I don't know if that's true increased virulence or an artifact of lowered testing. I do think, and I've heard other experts in this comment on this, that if you haven't been infected or you haven't been vaccinated yet, I think you're highly likely to be infected somewhere maybe by the end of the year or within the next year as Delta and other more infectious strains work their way through the population. Tim, I'll stop there for a second. I can talk a little bit about maybe 6 or 7 other slides on long COVID and some of the risk benefit, but I'll stop if we need to move on.
No, Dr. Carson, please proceed.
Okay, so I think as you're talking to your staff, as you're trying to work your way through this, we've got a lot of folks that just are making, quite frankly, very poor risk-benefit analysis for their own health and for those around them. And so one of the first things I would kind of just mention is it's not just about mortality rates. It's not just about dying. And I can show you, I could show you a lot of data that suggests that the minimization of mortality, like when you hear things like 99.8% of people survive, is really very flawed. But let's just talk about one aspect here, long COVID. We are getting huge numbers. There's like 2, 3, 4 new studies published on this almost every day. This was a systematic review of long COVID from 45 eligible studies, almost 10,000 patients. Majority were inpatient, so bear that in mind that these are people that were sicker. And at least 60 days of follow-up. Some of these are 4, 5, 6, 7 months of follow-up. And so in this review here, 72% of people have at least one or more symptoms at least 2 months out from their COVID. 40% fatigue, 36% short of breath, 28% memory problems, 22% new diagnosis or new problems with anxiety or depression, and about 15% having persistent taste or smell problems. This was outpatients, so milder disease. This was a study looking at prolonged symptoms in a prospective cohort of ambulatory patients, average of 6 months follow-up. And you can see in the over 65-year-old group, over 40% of patients had one or more symptoms. But even in the 18 to 39-year-old group, it's over 25% had one or more ongoing symptoms at 6 months. I mean, that's substantial. This was a study just published today, looking at symptoms at 1 year of follow-up. This was out of Italy, which got bombed by this at the beginning. And here I just plucked out one group, the 18 to 47-year-olds. So again, that sort of, younger, healthier group. Almost 70% had one or more symptoms out a year later. Fatigue in 36%, sleep disorders in a third, muscle and joint pains in a third, cognitive problems in 29%, respiratory problems in 27%. New England Journal just had an editorial saying we are going to be facing the next sort of big national health crisis, which is all the problems from post-COVID symptomatology. So I tell people, yep, you have freedom of choice, and the freedom of choice really is take the vaccine or take the virus, because I do believe everybody's going to be exposed to this at some that haven't had it already or haven't had the vaccine. You're going to be exposed to this sometime in the next 6 to 12 months, and you'll make a choice between taking the virus or taking the vaccine. And let's just pick one of the serious adverse events from vaccination: myocarditis. So myocarditis, and we'll take the sort of at highest risk group here, young males. So this is the breakdown of myocarditis or heart inflammation in cases per million doses. And let me just look at this particular age group, 18 to 24, about 45 to 56, or on average right around 50 cases of myocarditis per million, which has led some people to say, I don't know that I want my adolescent son or my young college son to take this vaccine. Well, this was a study that was done in the Big Ten, in Big Ten athletes. So a big study, almost 1,600 student athletes. So that's that 18 to 24-year-old age group. And they looked at myocarditis from the virus. So what percent of people get myocarditis when you actually look for it? And they did cardiac MRI scanning on all these Big Ten athletes. And it ranged from 0 at a couple of the universities up to a high of about 7.6% of these athletes having evidence of myocarditis after their COVID, which by and large was mild to asymptomatic. On average, 2.3% of Big Ten athletes had myocarditis from the virus. So, yep, you have a choice. And if you're a healthy young male where you're kind of trying to make that choice between the vaccine and the virus, a vaccine has about a 1 out of 20,000 chance that you'll have myocarditis, which overwhelmingly they recover from and have no sequelae or seem to have no problems, versus the virus, which is about, now by that study at least, 1 out of 43. I mean, to not do the vaccine is just very poor risk-benefit analysis, very poor math. I'll take one other example here, blood clots from the J&J vaccine. We're not giving that much J&J vaccine anymore, but J&J vaccine had overall risk of blood clots in about 1 out of 310,000 Contrast that with you do an overseas flight or a flight more than 4 hours, you got about a 1 out of 5,000 of having deep vein thrombosis. Or if you're a young woman on an oral contraceptive, you got about a 1 out of 2,000 chance per year. I mean, these are risks that people take all the time, but shy away from a vaccine that will prevent much, much, much greater chance of morbidity, hospitalization, mortality because of fear of something like blood clots. So again, this is just bad risk-benefit analysis. So when I see these sort of numbers in our nursing home staff, so thank goodness, as Jenny said, we've got like overall 92.6% of our residents with 2 doses of the vaccine. But having, and I'm just picking the first dose here, having on average 65% of our nursing home staff immunized, frankly, it's just unacceptable. To have 35% of our staff still coming into the facilities with the potential to be carrying the virus is unacceptable. And if you haven't heard the case of the Kentucky nursing home yet, and I suspect many of you have, but if you haven't, you should pay close attention, especially you who are in leadership positions in your nursing homes. You don't want to be this news story. In this Kentucky nursing home, this was published in Morbidity and Mortality Weekly just about a little over a month ago. An unvaccinated worker came into that nursing home where they had 83 residents, 116 healthcare providers, and they were all offered COVID vaccine previously. 90% of their residents were vaccinated, 52% of their staff were vaccinated, not unlike a whole lot of our facilities here in North Dakota. And on March 1st, one of their staff, an unvaccinated symptomatic staff member who passed their screening tests, came to work carrying a new variant. It wasn't Delta, but it was one of the new variants. And he exposed a large number of the residents and staff to this new variant. What happened? So he came into the facility, and of the unvaccinated residents, which there weren't very many, 6 out of 8 of them became infected. 2 of them died. 4 out of the 6 out of the 8. I'm sorry, 1, 2, 3, 4, 5 out of the 8 had symptoms, and several of them were hospitalized. 4 of them were hospitalized. Of the vaccinated residents, actually a good number of them got infected as well. Now, it was a much better protection than those unvaccinated residents, but he still was able to transmit it to them. And 1 of them died. And several others were symptomatic. Most were asymptomatic. So the vaccine protected completely a large number of them and led to no symptoms in a good chunk of them who got infected. But it led to symptoms in 5 of those, and 1 of them died. So the overall attack rate in the unvaccinated group of residents was 75%, and the attack rate in the vaccinated residents was 25%. That dropped down to a symptomatic rate of only 8%. So the vaccine efficacy was against hospitalization or death was 94%, 25% death in this unvaccinated group. And among the staff, he infected a good chunk of those that were unvaccinated, and even a handful of staff that were vaccinated. So there was an attack rate in the staff of 30%. 30% from this one individual ended up infected, having to be quarantined, having to be isolated, et cetera, et cetera. So that's a disaster for a nursing home, from one unvaccinated individual bringing in basically with the current conditions we have here in North Dakota. So I'll stop there, and maybe I guess we're going to maybe take questions at the end.
Thanks very much, Dr. Carson. That's very informative. Appreciate that. Let's go ahead and move on to the next area, and we'll be coming back for questions at the end of the presentations. We have Faye Salzer up next, and she'll be talking about Project First Line. Faye?
Everyone. I just wanted to remind those of you that haven't been receiving our emails that we do have a new program going called Project First Line. It is in collaboration with the CDC to provide training for all of our congregate setting staff. And we have 5 topics that we've already done, but they are recorded and posted on our webpage. There is continuing education credit for those. They are done in specific groupings for your jobs. So we have the professional licensed staff. We also have corrections, group homes, the public health unit, as well as our frontline staff, such as our CNAs and our EVS, our dietary, all support staff, including activities, etc. So those are currently recorded. There's 5 topics: the concepts of infection control, the basic science of viruses, how viruses and droplets are spread, how viruses spread from surfaces to people, and how COVID-19 spreads. It's a review of that. And so those are currently recorded. In your email today, Vanessa sent out the poster that has the link for our webpage. And then coming up, there are 3 new topics. The next one will be multi-dose vials for the professionals in local public health. And then we have another one on eye protection and one on gowns and gloves. So if you're struggling with infection control or having a lot of high staff turnover, new hires, you're using travel staff, these are really good for those frontline staff, especially to review, as well as your hands-on professional staff. It's good education, or if you're having surveys and getting deficiencies in infection control, we also strongly recommend that you have your staff view these recordings. And then I also wanted to remind everyone that we are doing the in-person ICAR, which is the Infection Control Assessment and Response. And you can just email myself or Nicole Linick if you'd like one of those at your facility. So if you haven't been around when I did those previously, the benefits of the assessment is basically a fresh perspective on your existing program. We help you to identify any gaps or weaknesses you may have and give you some recommendations on how to improve that for quality, as well as it helps you prepare for your regulatory surveys. It will also help you with your infection control risk assessment so you can prioritize and plan your activities for that. And it also will help your facility look at its capacity to detect, report, and address any healthcare acquired infections or outbreaks that you've had in the past and how to prevent them in the future. And then, as everyone else has been saying, with the new variant coming, we know everybody is getting COVID fatigue, but we strongly encourage you at your facilities to look back at the peak of the pandemic, what was working for you, if you can still implement that, what you struggled with, had problems with, come up with solutions for that so that we're prepared if we do have another surge. And one of the main parts may be that I know a lot of facilities have filled their bed openings that they had at the peak of the pandemic. So be prepared and look at where you're going to put any positive cases you have, since you may not have a COVID unit anymore. Maybe you've disbanded your unit or you filled all your beds so you don't have those separated units or rooms at the end of your hallway. So please make sure you're thinking of that, making sure your processes are still in place and that you have the ability to continue to implement, continue to screen everybody that's coming in, make sure people are wearing masks, and just keep educating your residents, your staff, and your families, because sorry folks, but we aren't out of the woods yet. So everybody stay alert. And having an ICAR in person, we can also help you address and work through those issues as well. So again, check out the Project First Line page, as well as reach out to myself or Nicole Linick to schedule an in-person visit at your facility. And that's all I have. Thanks, Tim.
Thanks, Faye. Well, we've reached the end of the biennium, and that means it's time once again to renew memorandums of agreement. We have a statewide coalition that consists of a wide variety of hospitals and long-term care facilities and so forth. And as part of the preparedness response activities, we maintain these memorandums of agreement to facilitate the response activity at the time that it occurs. With those in place, we already know how funding can be secured and distributed and what the rates and so forth are for the services that are provided. It also gives us an advantage if we have FEMA funding to have these in existence prior to the emergency. The Long-Term Care Association is an important partner in this process, and Vanessa's been working very hard for completing these memorandums of agreement once again. And so, Vanessa, let me turn it over to you and find the additional information that you have for us today.
For giving them the background on that. I appreciate that. I don't have a slide presentation, so I'll just hold it up to my camera, see if you can see it. This is the form that you would have received I got a little too close. This would have been the form you would have gotten in your email around July 7th, 8th, or 9th. I sent them out to administrators. And I did ask you, the subject line was, please sign and return. If you need to look for that email, please sign and return. And I gave you a date of July 30th. I know that's past the date that it became effective, but we were, with COVID, we were a little bit behind on everything. So just get that in as soon as possible if you have not sent yours in yet. And if for some reason you cannot find an email that I sent to you on July 8th, 9th, or 8th or 9th, please let me know and I can send that out to you again. And all you need to do is sign page 1. On page 2, there's 2 areas, 2 statements to read through. The first one is regarding care, if you can provide care. The second is if you can provide transportation. And if you can, please initial. And then if you are able to provide transportation, down at the bottom of page 2, there is a chart that you can fill out that says how many vehicles, how many seats do these vehicles have, wheelchair capacity, and stretcher capacity. And even if you are not able to provide care or transportation, please send both pages back to me. That's going to be very important because it's not complete if I don't have both pages. And once again, do that as quickly as possible or by July 30th at the very latest. That way we can keep these moving along. And once I do have a completed MOA with the state signatures, I will then send them back on to each facility. So that's all I have, Tim, on that subject.
Great. Well, Vanessa, I know you've also been working very hard on the upcoming Long-Term Care Association conference, and there are some preparedness topics there as well. Can you keep speaking to that?
Yes, definitely. Thank you, Tim. And gosh, I do a small portion of that planning of it. Normally that is Peggy and Miranda that do all that planning. And I just have a few sessions that I help out with. And I just want to make sure people know that it is August 24th through August 27th. And if you have not registered, please do so. Unfortunately, you have missed early bird registration. That ended yesterday. But we do have, it looks like about 6 sessions that will help you out in your emergency preparedness. The first one is a tabletop, and we're all tired of COVID, and we're all tired of any other type of chemical or whatever. So we're going to go with the next big topic, cybersecurity. That's really been out there. So cybersecurity tabletop. We'll do incident command system. I know that some facilities are very small, and you probably thought, how do I set up my incident command? I don't have enough people for all the positions they want in incident command. Sherry Adams, she will walk you through that at that session, let you know how you can set up your incident command in your small facility. Also on Wednesday, we have Life Safety for Basic Care with Dave Nelson and his team of Kevins to talk with facilities. And then Thursday is a day of all hazards security assessment with Don Ronsberg from the Department of Homeland Security. He'll be giving that session. He's very passionate about facilities, making sure they have a secure facility if there be active shooter or any other type of security risk in your facility. And then we have the last session for life safety code for skilled nursing facilities with Dave and his team of Kevins again. On Friday, the last day, we have our own from the Department of Disease Control, Department of Health Disease Control, Faye Salzer will be in person at the conference. So if you want to be with Faye in person, she will be Friday morning at 9 a.m. So please sign up for that session. Once again, August 24th through the 27th. And that's all I have regarding the convention. Thanks, Tim.
Thanks, Vanessa. Shelley is here also to this time talk about the funding. And so, Shelley, go ahead, please.
Kim, I do have a small update, different from the one about a month ago. But, you know, what happened in the last month, as we all know, is the Crosby Nursing Home announced closure. And they were, they were struggling before COVID, but COVID, really put everyone over the edge. Occupancy has been an issue, as well as just getting staff and not having to rely upon contract staff. So we know that there are a number of financially stressed facilities covering nursing homes, basic care, and assisted living. This afternoon, we did submit to the Department of Human Services a request for financial assistance. We want all of you to be whole. We want all of you to be able to get through COVID-19 and the impacts of it within a reasonably good fashion. So we have been studying and analyzing the impact on you financially. I gathered some information and now this afternoon submitted it to the Department of Human Services. We will be requesting funding under the American Rescue Plan. As you know, North Dakota is receiving an enormous amount of money, and it is to look at the impact of COVID. So we've been working hand in hand with Chris Jones at the Department of Human Services, and we'll continue to work in concert with them on what we feel is a reasonable request to make you whole. So just know that that is continuing to move forward. And as you probably also know, that may need to wait for special legislative session approval. But we need to have it all done and together in a package deal, and that's what we submitted today. The other item of news is the portal for the funding through the federal government is still not yet open. I've been telling you every time I do an update, just wait, it's going to open. I don't know when it's going to open. It is very frustrating that it has not opened. HCA had a discussion with HHS, and they said they're trying to get it right. They're testing the protocol. We know that it was difficult to apply through there before. So just know that HCA is more hopeful that it'll be more sooner than later, and that I will alert you when the portal is open, and we will encourage all of you to apply for funding. So in summary, then we're still looking at the federal funds and the federal portal that is not yet open, as well as we will be continuing to work very close with the Department of Human Services and Chris Jones on funding under the American Rescue Plan and making all of you whole. So that's it, Tim.
All right. Thanks, Shelley. Let's go ahead and move into the question and answer portion of today's program. We have a sizable group, so I am going to go around the state based on the largest cities, the 8 largest cities. And so whichever city that you think that you're closest to, when I call on that city that you're in that area, just go ahead and unmute your microphone and make your comment or ask your question. I'm going to ask that you ask your questions generically, and then whoever on the panel that has the answer and a response available can go ahead and respond to it. So let's go ahead and begin in the Fargo area. If you're in the Fargo area and have a question or comment on any of the topics that were covered today, just go ahead and unmute your microphone now and state your question or comment. All right, not hearing any in the Fargo area, let's move over to the Jamestown area. Any questions or comments from the Jamestown area? The Bismarck area is up next. Any questions or comments there?
This is Mel from Prairie Point in Bismarck. Wondering if we could get a copy of the slide presentation from Dr. Carson. I know my unvaccinated staff, I will hog tie them to a chair and force them to watch. That was really informative, and I really appreciated the passion with which he spoke about it as well. So that would be helpful.
Thank you for that, Mel. And I'm going to just quickly insert that We will have the video available with Dr. Carson's information that's part of that video. But Dr. Carson, can you speak to, would just the slides be available?
I can, just for ease of kind of sending around, I'll convert it into a PDF and you can use that. And you can pop those up just like a slide too. Yep.
Thank you so much, Dr. Carson. Craig, your hand is up.
Thanks, Tim. Question is that during our last surge of COVID, the State Health Department recruited nursing staff and CNA staffing. With the Delta variant coming in place now, is the state looking at regrouping and again recruiting staff again in the situation that nursing facilities are having difficulty with that variant and having staffing issues?
So the short answer is that we still have staff in place. At our peak last winter, we had just under 450 temporary staff that were with us. That's a smaller workforce currently. I think we're at about 270 now, full and part-time staff. And it is our intention to keep that staff in place. They are very busy assisting with vaccinations, fit testing, would still be available for what we call gap filling, as if in fact outbreaks were occurring once again and we needed to provide staff into facilities. So we're keeping a very close eye on where the variants are going, fully recognize that this is not over, and so we want to make sure that we're not standing down too far. But the short answer is yes, we will be in that same position to provide that assistance, and that assistance is still available even today.
Request process for assistance with staffing would be the same?
It is, and just to refresh everybody's memory, or for those that may be new, if you need staffing assistance that's part of the state staffing COVID response team, just contact our Emergency Operations Center. That number is 701-328-0707, 328-0707. The number is available 24 hours a day, 7 days a week.
Thanks, Tim.
Thanks for that excellent question and the opportunity to talk about that. Janessa, your hand is also up.
I'm wondering if there's any updated information as to when the vaccines may become fully FDA approved and no longer just emergently.
Thanks, Janessa. Anybody on the team on the panel want to attempt an answer to that?
To that. So the long answer is we don't really know for sure. There's still a lot of wiggle room in there. But what we're hearing is that likely both Pfizer and Moderna will be approved for 18 plus towards the end of this year. Hopefully late fall, early winter. We've heard Pfizer will likely go first, and Moderna could get pushed over to early 2022, but not for a while still.
Thanks, Jenny. So I think we left off in the Bismarck area, if I'm remembering correctly. Let's see if we have any other questions or comments from the Bismarck area. We're on to the Dickinson area now. Go ahead and unmute your microphone and state your question or comment. Or if you want to get fancy, you can also raise your hand like some of our peers have been doing. There's a function to raise a hand, and that we can call on you that way as well. All right, not hearing anything from the Dickinson area, let's head on over to the Williston area now. The Minot area. Go ahead.
I had my hand raised. You didn't call upon me.
Dr. Kelly, I'm so sorry. Didn't get there. Didn't see it in time. I'm glad you just unmuted your microphone and spoke up.
You're truly forgiven. Through a third party, I have asked this question of you, and I'll ask it of Dr. Carson. Any instinct as to if there is going to be another surge, and I hate to use that word, relative to the Delta variant, any perception as to how far out that is as we try to be prepared?
Well, I think we have some pretty good hints of it from, as I showed with the UK and Israel, better vaccinated countries than ours, and they're in another wave now. And we've got a hint of that with Missouri and Arkansas that are in a surge and having their healthcare systems stretched and taxed again. And we have just, I think, slightly better vaccination rates than Missouri, Arkansas. So I think we are just around the corner, I suspect, of having another wave. Part of what might be driving those waves is, they're in, at least as far as Missouri and Arkansas, and probably Israel for that matter, are in, hotter climates in the summer kind of now. So they may be doing more things indoors, which helps facilitate transmission, where we're probably not quite that much here in North Dakota. But I certainly suspect with the start of school again, as Delta is making its way further in North Dakota, we'll see another wave. I still am cautiously optimistic that we won't see here in North Dakota. I don't know if this is right or not, but I'm cautiously hopeful that we won't see a massive strain on our hospitals again, because we do have pretty good rates of vaccination in the people who are most vulnerable to requiring hospitalization or being at risk of dying. And that is, people over the age of 65, 75. The rates there are pretty good, and the vaccine seems to work. But I think we're going to see, and in the counties where we have very low vaccination rates, we'll see little mini pockets of flare-ups in various towns and counties in North Dakota, I suspect right around the corner in the next few weeks.
And if I could also just kind of add to that, I know that Dr. Kelly did raise this question through a third party, and we're going to be having some additional conversation about this with the hospitals next week when their tactical meeting occurs. But I just want to share with you that at this point, the specific steps that we've taken within this program have been to, number one, what we've already talked about, and that is to make sure that we have an adequate level of staffing still in place, still in a position to have a strong response. Again, we're not at where our peak level was last fall and winter, but we still have a significant workforce that's available for that response. The second major strategy is to make sure that we had adequate PPE in place once again, that we were able to replenish our supplies back into the state medical cache. And we have successfully accomplished that. We're in as strong, in fact, even in some areas, stronger position than prior to COVID-19 starting in our state. So that has been resolved. And then in addition to that, and obviously with all of this, we don't want to go down these paths, but in really severe cases, we do have an additional quantity of ventilators that are now part of the medical cache. They are shipped, and we'll be adding an additional 50 ventilators in the appropriate circuits into the state medical cache for use if, in fact, at some future point we face a more virulent disease than we currently face with COVID-19. And so those are just some of the immediate steps that are short-term that we've taken to prepare, and continuing to do planning processes to see what other steps we should be taking as well. Thanks for the excellent question, Dr. Kelly. Any other questions or comments from the Minot area? And let's move over to the Devil's Lake area. And finally, the Grand Forks area. I'm going to do a last call for questions from anywhere in the state. Any comments or questions? Once again, there was just a ton of great information. I do want to thank our panelists for the incredible information that was provided. Shelley, do you have any closing comments?
Tim, just a comment about our meeting in August. The fourth Thursday in August is when our convention is going to be convening that week. At this point in time, I think we have 600 in-person participants. And of course, we probably will be masking and everything else that goes along with the precautions. But so our August call is going to interfere with that. So I just want everyone to know we will likely reschedule that. And Tim, will leave it to your call if we do it the week before, the week after, or if we could wait a couple months. I know with all the uncertainty of fall and summer beginning or school convening, we might, so just know everyone that date will not be able to occur because of our convention, and we'll see many people at the convention, and Tim and I will work on what is the best rescheduled date. But wish you all well and look forward to seeing many of you next week.
Thanks, Shelley, and thanks for the heads up on that and that conflict. We will get information out. I'm hesitant to just cancel it, so I think we're going to want to get something scheduled just so that we're getting closer, that we've got something marked and that we could be reactive if necessary. So we'll get some information out about that. And again, thanks to everyone for your participation today. Remember that this program is archived on our website at www.ndhealth.gov/ET, and so you can avail yourself to that if you would like to at a future point. Take care, everyone.